3 full days of presentations, but it's a really good opportunity for you to hear what everybody's been working on. I know you've all been working really hard on your projects the last several weeks, but we're week 7. Next week is our last week of the course. I can hardly believe it, but so now I've looked at all your materials they've turned in. Everybody's done a really great job so far, so I'm really excited to hear your presentations. One thing before we get started is that please, I'm asking you to please be respectful of your classmates. You know how much work you've put into your project, so is everyone else. You do not need your computers, so you can put. Okay, and I just want to remind everybody that we can see, just because we're a distance, we can see each other on. So today we're presenting from Winnemucca. We can see you in Elko and Pahrump, so I'd appreciate there shouldn't be side conversations or things going on. It's just respectful to your classmates. Same goes next week when we're presenting from Elko. I mean, we can see the Winnemucca and Pahrump sides very clearly. So we can tell if you're having side conversations or have the mics muted and are doing those things. And it's just not very professional or respectful to your classmates. So I hope you can give each other that respect. Yes, you don't have to submit. If you would like to submit something online, you can. You do not have to. I'm grading them as you present. And Professor Meddy's here too. So we're grading you as you present, not to make you nervous or anything. I'm sure everybody's going to do great today. Any questions before we get started, really? No? Good.
I just have one question since I'm going first. I did have Professor Rust fax over, it's called the Comprehensive Surgical Checklist, just because it was really slow. Okay, good. It looks just really bad on my PowerPoint, so.
No, on our end it looked fine. I can see it.
Okay.
Just give me the high sign when you want me to pass it out.
Okay. You can pass it out now if you want, because I go first.
Oh, okay. I will do that right now.
And we put one right there.
Oh, thank you.
You want me to pass them out so you can get your glasses?
Yeah, would you? Thank you, Stacy. Good luck, Winnemucca.
Thank you.
The computers.
Oh, you go to the control office and you pay your $20 if you want to.
We'll have to switch.
I know. $20 and $35 if you want it sent in the mail.
Is that include our cups down?
Oh, you should come on. No, does it include our capital down? $300 to apply.
Hold on, let me get that camera on Bianca.
35 is you pay that, and then they give you your receipt and your application.
You are.
That into the
There we go.
front.
Oh, and zoom in. Sorry, okay.
In the administration office.
Thank you.
Can you guys see both her PowerPoint and her?
Yes.
Okay, perfect. Thank you.
Bianca, do you want to move that?
Yeah, it doesn't.
We just move it, the whole thing?
No, no, it doesn't. I know. It's so. You can.
What if we flip it the other way? Short view.
I'll bring it twice. I know, the arm in the side.
Well, I don't think it does that. You can stand a little bit to the side.
Just
There you go.
That's better. I'll stand right here. Okay. Thank you. All right, so I'm going to go ahead and start if everyone's ready. So I did my evidence-based practice presentation on a timeout. So I'm not going to do it on what a timeout is. I'm going to do it on timeout compliance. But first, I'm going to start off with talking about what a timeout is, for those of you that don't know. So a timeout is part of a surgical safety checklist. This checklist includes check-in, timeout, and checkout. This is the time, this is a pause right before surgery begins, where everyone stops and listens to vital information that's being said about the patient. This information includes the identity of the patient, the team members in on the operation, materials being used, allergies, medications given to the patient, what the surgery is, and the surgical site. The timeout is normally called out by a designated team member, and here at Humboldt General Hospital it is a circulating nurse. Once the team member calls the timeout, everyone must stop what they're doing, listen to what she's saying, and agree to what has been said. So I have found 2 different checklists, one by the World Health Organization, also known as WHO. I'll be bringing this up a lot more in my presentation. And then the Joint Commission also has a checklist. So why is a timeout implemented? A timeout is implemented because it prevents unintentional accidents before surgery. Some of these accidents can include doing surgery on the wrong patient, doing surgery on the wrong site, or doing the wrong surgery and all. The staff in the operating room are only human, so accidents can happen, and a timeout does prevent these. WHO, the World Health Organization, found a decrease in post-operative complications by 30% and a decrease in mortality rate by 50% when a timeout was used in the checklist. This was a study done in 2013. A different study in the Netherlands done in 2014 said that there were 54% unintentional accidents that year in the operating room, and 34% of them could have been prevented with the timeout. So that's why it's so important. So why does a timeout work? So a timeout works because everyone is involved in the timeout. Everyone is listening to what is being said. Therefore, someone could catch a mistake before it happens. Let's see. Sorry. This all takes team effort and compliance from everybody, not just one person. So this is why the timeout works. Everyone's listening. Everyone knows the patient. Everyone knows the procedure that needs to be done. So, like for example, a patient comes in to get their gallbladder removed and the appendix site is marked. During the timeout, it should be caught that the wrong site is marked and prepped. So this would be caught, and then they would fix it right there before surgery has begun. WHO also conducted that a timeout in the surgical safety checklist can save up to 500,000 lives a year. And this was a study done in 2014. Okay, so now that you know what a timeout is and why it is implemented and how important it is, I'll let you know what led me to choosing this topic. So, I asked one of the surgical nurses from the OR if she would be willing to answer some questions for me, and she gladly said yes. I told her that I still had no idea what I wanted to do it on. I just knew I wanted to base my project on the OR department. And so she gave me some things she was concerned with, such as the cloth, like surgical caps that are cloth in the OR because they bring in bacteria. She said late charting or the doctor's not charting on time. And she also said the timeout. So when she said timeout, I thought about my clinical day at Humboldt General Hospital, and the nurse called the timeout, but nobody actually stopped to listen to the nurse. So she said everything that needs to be said, and then she hit that it was done. And so I asked the nurse I interviewed why a timeout was so important and why everyone needs to stop. And she explained it to me that it prevents the wrong surgery or the wrong site or the wrong patient. So it was really important. After that, I knew I wanted to do my research project on the timeout. So you can't really see it too well, but I'll explain it to you. I just put Humboldt General Hospital's policy up. So their policy states that the patient needs to be prepped and draped before the timeout is called. Then the timeout is called. Everyone needs to stop and listen to the nurse. So she says the patient's name and date of birth. She says the patient's allergies. She says the surgical procedure, the surgical site. She says the antibiotics administered. She has the patient in the correct position, and she says any implants the patient has if they're available. So after this, everyone needs to agree with the timeout, and if there is any sign of disagreement, the surgery has to be postponed. Okay, so again, sorry. Again, when I went to, when I thought back to my clinical day, I saw no compliance to the timeout. The timeout was called, but nobody stopped to listen and continued talking. The nurse said the things like the allergies, the medications, the patient's name, the date of birth, the procedure, but no one still, everyone continued talking. And then when she was done, she marked it as done in the chart. And so neither of this shows compliance to the timeout by the nurse or by the rest of the staff, because the nurse shouldn't have marked it complete as done because nobody was actually listening to what was said. Okay, so then this led me to my PICO question, which is how to improve staff compliance during a timeout in the operating room. So the first thing I found, the first thing I found were factors to adherence. So one of the major factors I found was a poor attitude from the staff. A study done in 2012 in a pediatric operating room said many of the staff members had poor attitude about it. They said that they made comments like the timeout was a waste of time, it slows down my work, there's too many irrelevant things on the checklist, I have less time with my patient, and some even said that the checklists were insulting because they were highly trained professionals. The same study saw inconsistency in the timeout, so sometimes it was done and sometimes it wasn't. When it wasn't done, it was because the team wasn't focused on the timeout, and when it was done, it was because they were all focused and ready to go. And then some people said that they had little or no training on the timeout, so they didn't know how to do it correctly. A study I found on an AORN journal, which is the Association of Perioperative Registered Nurses, said that the timeout, wrong spot. It was done in 2013, said that there's too many distractions in the OR, such as music and then people talking during the timeout. Other factors I found were the timeout is being marked as done when it's not done. That's also happening at Humboldt General, or if it's done incorrectly, so if they don't do it as policy. The study in the Netherlands I talked about earlier also found a few factors, one being old age. So they found when the client is older, I believe than 74, the timeout is less likely done, as well as the type of surgeon that is in on the procedure. So ears, nose, and throat surgeons, they did well on the timeout, and so did ophthalmologists use the timeout more. And they also found teaching hospitals also had a higher rate of using timeout because they're teaching the new people coming in how to properly do procedures. They found communication errors, and there was no leader involvement. So the leader can include the OR managers or any other manager who is in charge of them. So those are factors done in a research article I found in a hospital of Austria in 2015. Let's see. And then when they're on day shift as well, day shift uses the compliance more, or complies more with the timeout than night shift does. Okay, so after reviewing all my articles, I summed up 3 recommendations that pretty much all of them had. So there was leadership, education, and audits. So I'll start with leadership. Okay. So the Hospital of Graz, the study done in 2015, said that a positive leader will increase compliance with the OR because the leader is open and she or he are in on the timeout. So it shows like if there's negative, it just kind of makes the culture of the OR unit. So if the leader doesn't use the timeout, neither will anybody else. And if the leader is positive and ready to use the timeout, everyone will comply as well. The same study also suggests that maybe the timeout should be surgeon-led, just because it said that the surgeon is more powerful than the other staff members. So they found, I think, an increase in 90% when it was surgeon-led. Then the last one I did is making it a team effort, so everyone has a role in the timeout. I found a timeout called the Minnesota timeout, and this was done in 2012. And this involves every member in the operating room to participate. So then I just brought it up. So the first thing, it starts with the surgeon. The surgeon will call the timeout. And then step 2, the circulating nurse will read directly from the patient's consent form, and she'll say the patient's identity, name and date of birth. She will say the site and then position the patient's in, and consent and procedure. Next, the anesthesiologist will say the medications and any allergies the patient is on, or allergies the patient has. And 4th step is the scrub tech. The scrub tech visualizes the site and tells that make sure it's the correct site marked. And then finally, the last step goes back to the surgeon, and the surgeon finishes the timeout with, again, saying the patient's name one more time and the procedure being implemented. And this, again, was done in 2012. Okay, so the next recommendation is education. So the study I mentioned earlier in 2012 in the pediatric hospital said that all employees need consistent training with the timeout. That way it's done the same each time in the operating room. A different study in 2015 had similar advice. They said that the training, so they did like monthly trainings, and they were repetitive trainings. They didn't change anything. Everything was the same. And because when somebody hears something, it will stick. That same study I mentioned earlier says to bring in a coach in for training. A coach will actually train everybody individually, and he or she will develop expert teams. That way everyone is on the same page, everyone knows how to do it, and then they have the coach, and the coach does everything evidence-based as well. So during educational sessions, the team needs to be reminded of how errors are reduced and why the timeout was implemented. So again, the World Health Organization, known as WHO, says checklists reduce morbidity from 11 to 7% and mortality from 1.5 to 0.8%. And then that pediatric hospital also even set up a YouTube video on how to do the timeout. I actually tried looking it up to show you guys, but I couldn't find the YouTube video they used. But I have a different one uploaded for you guys. So lastly, the last recommendation I found was audits. So 4 of the studies that I found also used audits. So some of the audits were done randomly, and then others they told them when they were going to do the audit. And the audits just help the hospitals know how well people are the staff is complying to the timeout, and if their training worked. The study in the Netherlands found that their timeout was only used 73.3% of the time. Another study in Austria found that originally their compliance rate was 77.1, but then after training it was 99.2. A study in particular from the AORN journal, again known as the Association of the Perioperative Registered Nurses, did noise audits on their staff. They didn't say any statistics on how it worked, but they had the circulating nurse turn off any musical devices that were playing in the background, and then say the timeout as well before starting. So they did the noise audits, and then getting feedback from staff after the audits. One of the studies did a survey, and the staff would go in and fill out the survey, see what they thought. So consistent feedback from the staff is also important because it shows that they're also in on this, that this is their area of expertise. So just getting staff from them, like, did the timeout work, why isn't it working, and stuff like that. So one of the research articles by the author Tadasi and Gasha, this was also done in the World Health Organization, summed up pretty much everything I found in one article. So they say, to establish highly successful implementation process of a surgical safety checklist, every healthcare provider, including the hospital managers, have to actively lead the process, deliberately enroll to the work, create an extensive multidisciplinary discussion and communication, arrange update trainings, offer ongoing constructive feedback, and conduct regular audits. So everything I found, all my other research articles were summed up in this one article done by the World Health Organization. Okay, so now I'm going to tell you my recommendations. So, what do I recommend to Humboldt General Hospital? So, first, I would recommend retraining all staff consistently. That way, each member knows exactly what they need to do and what their role is in the timeout. Their education training could be monthly or bi-monthly, just depending on how well everyone is complying to the timeout. Is it improving or is it not? Do they need to change how they're educating? I would also recommend these meetings be mandatory. Just have different dates set up and then have somebody go on the day they could go. That way everyone goes, including the surgeons. That way everyone knows what to do, everyone's getting trained the same, and the compliance could increase. Next, I would recommend bringing in the coach to help with the training of each staff member and then make the expert teams like I said earlier. Then I would recommend doing the audits as well. As I said earlier, the studies show that audits help increase staff compliance. When doing audits, they should also do the noise audits as well to make sure there's no music playing in the background when the timeout is called. And then after the timeout is called and they start, the circulating nurse, because she is not surgically prepped, she can go in, she's not sterile, she can go in and she can turn the music back on for everybody. So the circulating nurse, so here at Humboldt General Hospital, the circulating nurse does set the timeout. And if the compliance rate doesn't increase with that, maybe they should try the Minnesota timeout, having everyone have a step in the timeout. The anesthesiologist, the surgical tech, the surgeon, and maybe everyone will be quiet and listen, and it'll be done better that way. Or they can have the surgeon lead the timeout, because that also improves compliance rates. Although Humboldt General Hospital already has a good policy in place, it was done in 2013, and they got theirs from the AORN Journal website, and then 2013 it was revised, and they have actually updated a new one since 2016, and this is the one I have added. So that is the paper. It kind of looks bad on here, so I gave you guys all a paper of what the checklist includes. So we're just kind of focusing on the timeout. They have added the introduction to all team members. Oh, and this comprehensive surgical checklist joins in the World Health Organization checklist and the Joint Commission checklist. So it's all of them combined in one, and this just enhances the timeout policy. So maybe when they're retraining their staff, they could implement this comprehensive surgical checklist, and it has everything. So they have added the introduction of each team member, any equipment concerns in the timeout, anticipated blood loss, and then the fire risks. Okay. So how would I start with implementing my recommendations? One of the first things I would start with is start with talking to the OR manager, and she's the leader in this. Just getting her input and see what she thinks of the timeout, how often she thinks it's being used as well. It is important to get what the leader thinks, because it greatly affects the adherence to the timeout. Like I said earlier, if the manager is negative about it, that's why they don't comply, because the leader is not positive. So when the leader is positive, it shows more compliance. So after talking to the manager, I'd want to do an audit on the floor to see how the OR is doing with completing their timeout. Most of the audits that I found were done for about 4 months to a year, and they were done randomly. So somebody would go in there on a random day and then do an audit, and they wouldn't say that they were a person from the audit team. They would be dressed up and just saying that they were observing. After the audit, I would see like how it worked, see what the numbers are at Humboldt General Hospital, and I would just bring in a coach to start educating and training. So a coach will help and direct staff on the timeout. The coach can show especially the circulating nurse and the manager how exactly to do the timeout. And I would also start bringing in, again, statistics of why the timeout is so important. Just kind of remind everybody that it's not a waste of time. It does save lives. It's proven. And just show everybody, again, why that timeout is done, to prevent wrong surgery, wrong patient, or wrong site. So as well, I'd also talk to the surgeons as well, because it's helpful to see what they think from the timeout, just because everyone listens to the surgeon. So having the surgeon also have a positive attitude would be important. And then after implementing these new strategies for the compliance, I would like to interview the staff. Getting staff feedback, I think, is really important, because it shows what could we have done better, what was done great. And then after getting all their feedback, continue training, and then continue doing the audits as well. So lastly, what would I like to see improved? So improved staff compliance, positive attitudes from everybody, decrease adverse effects. I didn't get Humboldt General statistics on the adverse effects, but just having a decrease is always better. Having a hands-on leader, having consistent training, and then repetitive training, and then just continue feedback from everybody as well. So I have given you guys an example of a timeout, and this one is done by the World Health Organization. So Humboldt General Hospital doesn't do it this way, but this is just an example for you guys to see of how a timeout should be done every time.
Okay, everyone, looks like we're all set. So this is the first case today. So can anyone just identify themselves? My name is Tom Weiser. I'm a circulator. Tool 1, you surgeon. Surgery. Nurs258.
Alex Haynes, anesthesiologist.
Great. Okay, and Dr. Dwande, can you identify the patient and the site and procedure, please?
So this is Richard Wright. This is for a longitudinal hernia repair. The site marking is showing.
Okay. Any critical events or steps that you anticipate?
No, this is a routine inguinal hernia repair. Should be under an hour and minimal blood loss.
Great. Anesthesia problems?
No problems. Healthy guy.
Great. And Laura, you're all set?
I'm all set.
Did you have your mesh?
I do.
Antibiotics have been given?
Graham Adams was in 5 minutes ago.
Okay, and Dr. Dwande, do you need any imaging?
No imaging needed.
Okay, I think we're all set. Thank you.
And this was done in 2013. So, and that is all I have. Thank you. Does anybody have any questions? No? Okay.
Questions for Bianca?
Thank you. Have my references.
I have a question.
Yes.
So the timeout procedure, the patient was already, looked like they were sedated?
Yes, so the patient is already sedated. So the patient is prepped and they're already draped. So they're already ready to go. So the timeout is called right before they start. Okay.
Thank you.
Thank you.
Hey, Professor Warner.
Yes.
I was just looking at the schedule for all of the presentations.
Yes.
And I don't think the rooms are correct on Tuesday.
Okay.
Because we have mental health in 108 here in Elko on Tuesday morning.
It's 107. Sorry. You're correct.
Yeah, and I think our first year students are going to be in the ambulance barn.
Winnemucca will be in the ambulance barn in the morning, and if it says 108 on there, it actually should be 107, but I'll verify that.
But you guys will be in the regular classroom, right? Because we'll be in our first year students will be in the barn, right?
No, we should be in the barn. Second year should be in the barn for the presentations. That's why I didn't schedule them Tuesday mornings there in Winnemucca. And then in Elko, we should be in 107, I believe, all day, but I will look into that to make sure.
Okay, and I can look, I've got the calendar in my office. I can take a peek at the break.
Okay. Yeah, on this flyer, I see, I have it backwards somehow. I didn't catch it. The afternoon session is actually the morning. I'll fix it. Sorry, guys. Okay, Kristen.
Hi. Do you want to adjust me a little? I'm just a little taller than Bianca was.
Yeah.
Thank you. That looks better. All right, may I begin? Okay. So today we will be discussing foot traffic in the OR and its impact on surgical outcomes and patient safety. I have completed my evaluation on Humboldt General Hospital, and the recommendations and information set forth are based upon HGH only. Humboldt General Hospital provides surgical services to rural northern Nevada Monday through Friday and is on call for emergencies. The facility offers general, orthopedic, endoscopic, and a variety of specialty surgical services, such as eye surgery, podiatry, and obstetric services. HGH provides surgical services to the community of Winnemucca and surrounding areas without the additional burden of travel. HGH has 3 surgical suites, 2 of which are operating rooms and 1 procedure room. The hospital has undergone extensive renovation and updating. The surgical department was finished in September 2017 and includes all of the latest advances in technology to improve patient care and maintain a sterile environment. To learn more about HGH's surgery department, I spoke with Adeline Gomez. She's a registered nurse that began working in the OR after graduating from Great Basin College. She and I discussed various aspects of OR nursing, such as job satisfaction, skills necessary to be successful in the OR, and issues within the department. One of the problems identified and we discussed further is the high level of foot traffic in and out of the operating room during procedures, especially total arthroscopic surgeries. She mentioned that the foot traffic policy is unclear on the rules and the staff is having a hard time complying to the policy. To gain a better understanding of the problem, I researched the current hospital policy. HGH's current traffic control policy states, all traffic within the operating suite is kept to a minimum. The number of individuals in the operating suite is kept to a minimum. Doors to the operating suite are closed, except when necessary for movement of personnel and equipment. HGH's current policy aims to reduce foot traffic in the OR, but unfortunately, as written, is open to interpretation and unenforceable. The term minimum can be defined countless ways. Does it mean 3, 10, 0? The parameters are too vague for the policy to be effective, and as such, foot traffic in the OR is not well controlled. But why is limiting foot traffic important? Let's start with an overview of the operating room. Surgery is an invasive procedure that patients undergo in hopes of improving their overall health. Due to the invasive nature of surgical procedures that expose blood, bone, and tissue to pathogens, a strictly sterile environment must be achieved and maintained. Advances in current technology have given hospitals the ability to manage the OR environment at a much higher degree than ever before. The sterile environment must be maintained to prevent surgical site infections. Surgical site infections, or SSIs, are the 3rd leading cause of healthcare-associated infections. Contamination of the surgical site occurs mainly during the time of the procedure and leads to the development of infections. SSIs substantially increase the severity of illness, prolong hospitalization on average 7 to 10 days, and increase the risk of death up to 11 times. SSIs are a serious complication of surgery that must be addressed beginning in the operating room. To reduce the risk of SSIs, achieving and maintaining a sterile environment is crucial. Proper air handling is the single most important environmental factor in the prevention of SSIs. Operating rooms are maintained at positive pressure, meaning they receive only filtered air in and expel that air to outside areas. Unfiltered air is never pulled into the operating room. At least 15 air exchanges per hour are recommended. This kind of air management system requires that the opening of doors be limited to the greatest extent possible, as opening the doors can decrease the efficiency of the system. When air is circulated into the operating room, it must flow from the ceiling to the floor. Establishing flow in this direction minimizes airborne pathogens and prevents particles on the floor from being disrupted and brought into circulation. The use of a diffuser aids in preventing return airflow over the surgical table and keeps air from contaminating the patient. Now that we understand the importance of proper ventilation and its role in preventing surgical site infections, what happens when there's a high level of foot traffic in and out of the OR during procedures? Does traffic flow negatively impact patient outcomes? Airflow and ventilation systems cannot work effectively at maintaining a sterile environment if the doors are opened frequently during surgical procedures. High airborne particle concentrations are generated due to air turbulence from opening a swing door, such as the double doors in the OR at Humboldt General. Looking at this image, it is evident that opening the door spreads contaminants and particles into the room very quickly. The top of the image is particles spread within 1/10 of a second. The next image is particles in half a second, and the bottom image is in 1 second.
Can you just stop
Of
for
a
a
swing door.
second? I'm sorry.
Sure.
Is there any way, Professor Warner, that you can zoom in on these slides because they are not readable at all in Elko? Like do the,
Let me see what I can do.
like roll the mouse?
Yeah.
I know, I'm looking at it and I go, that looks tiny. We can,
I don't know if it's making the. Sorry. That's not working. Stacy, you have ideas here?
hold on, if we exit this way, no, not that way, come out of this, we can come down here. All right, we looked at it yesterday and it's all better now.
And this one usually is more clear and that one was fuzzy.
But I don't know. Is it all zoomed in now?
Hold on.
Okay, now maybe we can zoom out on this screen.
How do you do that?
Uh,
You just want to do it on the computer?
Sure.
Click on that. Like. My scroll bar.
I worked on this too to make sure you could see it.
Oh, here. Nobody else's.
Oh,
Yeah, they have got all their stuff.
I know.
I zoomed in. Here,
Oh, wait. That's why it keeps resetting on us. Ah. Well, that sucks.
We're just gonna have to
I think what's nice about it.
turn around.
Send it to instructor med.
Yeah, do you want to send it?
Sure.
Just send it.
Invested.
Okay.
Not text message, but in.
Well, we can send it to, maybe,
Far more interesting.
Is it not working?
I can't zoom in. We can send it to you and you can pull it up there, maybe.
That's fine. Is there, like the picture that she was just talking about, can she zoom it, like go in and out of this, on the slides? Because she's talking about that picture, how it was illustrating.
Right.
Why is this on here?
I don't know, I don't
and it's just hard to see the,
Because now we've zoomed in.
No, it's just because we're super zoomed in.
Well, see, that's what I get for trying something new.
For you.
No, down a little more. That way.
I was gonna say, do you see my leg going 1,000 miles an hour over here?
What's that little thing at the, see the
It
little,
only has
the little
negative.
squares on the edge, the edge of a paper?
So that's just the slide.
I know, but I was thinking maybe right here.
Hold on.
Okay.
No, my fault. We can
I'll tell you what I don't like is getting something up there and then not really. Yep. It mortifies me.
Could you just,
Log in on that picture.
what? To zoom in?
Just on that picture.
Well, I was trying to
I like
zoom in and it won't let me.
emails.
I've already fixed it. Bye.
I don't think you're doing anything.
Well, I was trying to make it bigger.
What about that little one?
Sorry.
Okay. See, you can read it on here, just maybe not from the back of the room.
No, I can't.
Okay, well,
And I did try to make the font bigger, but apparently not quite big enough. Okay, can we
Okay.
continue with this?
do you want us to send it, do you want to send, Dr. Meddy, do you want us to send it to you?
If you want to, or we can just continue and squint.
I can post it in the on the page afterward if they want to flip through, or would you like to see it now? Oh, wait, no, don't go to the next one. I don't know. What would you like to do?
It's just,
If you guys can't help it, that's okay. We can just move on, keep going.
I tried, and then it's just messing stuff up, sorry.
Sorry, I thought we had it all fixed from yesterday.
That's okay. That's all right. That
Okay,
happens.
okay.
Believe me.
Okay. All right, so here we go. Air filtration and ventilation systems cannot work effectively at maintaining a sterile environment if the doors are open frequently during surgical procedures. Oh, well, hold on, we've already talked about this. So here we go. Foot traffic in and out of the OR leads to airflow disruption and airborne contamination, which increases the patient risk of surgical site infections. The video above, hopefully you can see that little bitty dots across the screen. It's just demonstrating particle movement of one nurse walking across the OR room. So as you can see, just the movement of one person causes a significant change to airborne particle distribution, and it's spreading contaminants. It takes, on average, 20 seconds for a double door to close completely. The national average of door openings per surgery in a 1-hour case is 45 times. That means that every 1-hour surgery, the door is left open to the sterile environment for 14 minutes. That's almost 25% of the surgical time. The doors are open and contaminants are being introduced to the operating room. This dramatically increases the patient's risk of developing surgical site infections. It's unacceptable, but can be corrected. As we have learned, ventilation systems cannot work effectively with frequent door openings, and it's unfairly putting patients at risk of serious complications. So what can be done? How can this problem be addressed? I have good news. To correct the problem is not complicated or costly. I have developed a 3-step simple plan to dramatically reduce operating room door openings caused by foot traffic, which will greatly improve patient outcomes and reduce the risk of surgical site infections. Step 1 of my plan is installing pull shades on the OR double doors and having these shades lowered during surgical procedures. Numerous studies have been conducted on reducing traffic flow. One of the simplest and most effective methods researchers found was using these pull shades to deter traffic. The pull shades give a visual reminder to outside staff that surgery is in progress and should not be interrupted except for emergencies. Using a pull shade on the OR double doors with the word incision notified personnel not involved in the procedure that the surgeon had opened the surgical site. The circulating nurse is responsible for pulling the shade after the timeout is complete. The installation of pull shades would have minimal financial impact and does not require extensive time by the circulating nurse to complete. The pull shades have zero negative impact on the patient, aid in maintaining a sterile environment, and cause staff outside of the operating room to pause before entering. So how effective was this intervention in studies? Researchers found that the installation of simple pull shades and the usage of these shades reduced door openings by 50%. That's astounding. This means that the door opened 50% fewer times. That means half as many airborne contaminants were introduced to the sterile environment. This decreases the patient's risk of getting a surgical site infection, and the air filtration ventilation system works 50% better. This simple strategy has the potential to greatly impact surgical patient outcomes. So one major cause of foot traffic during surgery is staff communication. Staff communication ranges from inquiries about the current case to staff breaks. A majority of communication with the staff outside of the OR is non-emergent. Non-urgent communication should be handled over the phone without entering the OR. Each operating room at Humboldt General Hospital is equipped with a telephone that has an individual extension that can be dialed from any HGH telephone. Additionally, a small placard can be placed outside of the operating room, listing the telephone extension and reminding staff to call if needed. By utilizing the telephone for staff communication, the number of door openings and foot traffic in the OR would be reduced. Using the telephone to manage non-urgent communication between staff is a cost-effective and easy solution. So lastly, opening the double doors during surgical procedures contaminates the sterile operating room with twice as many airborne contaminants as using a single door entry. Each room at HGH has a double door entrance and a single door entrance through the substerile room. The substerile room just houses some supplies. Encouraging the staff to use the substerile single entry door to enter an operating room in use would cut contaminants drastically. Accessing the operating room through this single door would reduce the risk of surgical site infections. It can be accessed by all staff members. Can be accessed by all staff members and does not drastically increase time of communication. It's very easily accessible to everybody. Implementing this recommendation would greatly reduce double door openings and thereby reduce airborne contamination. So how do we go about making these changes? First, the current policy must be updated to include these recommendations. In doing so, the policy must be more defined and enforceable. Staff cannot comply with policies that are vague and open to interpretation. Secondly, staff training regarding the new policy and practice is essential. Third, pull shades and telephone extension placards must be installed. Next, change is not possible without engaging all surgical staff members. There must be a change of environment that acknowledges the need to keep the doors closed, to maintain a sterile environment, and to keep patients safe. Finally, it's important to gather feedback from staff and address concerns and issues accordingly. These changes are not effective without feedback and support. So overall, these recommendations have minimal financial impact, require nominal staff education, have a negligible impact on staff time, and utilize resources already available in the operating room. So surgical patients at Humboldt General Hospital have access to state-of-the-art operating rooms in rural Nevada. To efficiently use these technologies, though, including the air filtration and ventilation systems, the door openings and foot traffic have to be reduced. To achieve this, HGH should install pull shades on the double doors, use telephone for staff communication, and encourage the use of a substerile single entry door. As always, the primary goal is patient safety and satisfactory patient outcomes. Sorry you guys couldn't see my presentation, but do you have any questions?
I have a question for you.
Okay.
Oh, I just have a question about the drapes. Did you find anything in your research about the drapes being a source of contamination? Being in that they would be difficult to clean, or keep clean?
I did not find much information about drapes because my focus was a little bit different.
Not the
I
drapes
do
on the
know-
window.
The shape.
Not, or
Oh,
the
the
shade,
drapes.
sorry.
I'm sorry.
Sorry.
No, that's okay.
I wasn't clear, sorry. Thank you.
Actually, none of the studies talked about maintaining them, whether they were clean or dirty. So I'm not sure how they are kept. I'm assuming it would be part of the housekeeping policy.
Gotcha. Well, there are those doors too that have the shades in between the glass. That, I mean,
Right.
and that would be more, higher expense to install, but I mean, that might be a better
Sure,
option.
but if it works, absolutely.
Okay, thank you.
Does Humboldt General have a do not enter line that separates like where the OR patients are versus where the OR staff is? Because like NNRH does, they have this big red line, and so if you're not in your sterile OR where you can't cross that line.
Sure, we have a sterile hallway as well that's marked with a big red line, and it's the entryway to the access doors for both ORs. So the long hallway would have both ORs on the side. The problem though is even though that hallway is technically sterile, there are still contaminants in that area that are being exposed when the doors are open. So it is, there, we do have that sterile area that you have to be dressed out to go through.
Who's opening the doors then?
Staff.
Staff who are sterile.
Yes. No, well, not always, yes. Yes. Staff within the OR.
Did you have a question?
Because don't they only require the booties and a face mask
And a
and
hat.
a hat when you walk in? So they're technically not completely sterile.
No,
but
they're not completely sterile, but they are
Right.
covered. So, sorry you guys couldn't see it. I did think it looked cool.
Yeah,
But
so we can see it.
I
Look
posted
cool.
it for you.
I would have loved to have seen some of your pictures that you talked about just close up. It would have been interesting to see that. And that picture of the nurse walking, or the animation thing of the nurse walking across the.
Right? Well, I
yeah.
apologize.
That's okay.
Technical difficulties.
That happens.
But I can
Kinda-
post that.
This is Gloria out of Elko. I have a question.
Sure.
As far as installing the telephone, did you say that was inside the OR room?
Yeah. At the circulator's desk, each operating room has a direct line.
Okay, so as far as your research, did you find anything about contamination with that? Like during the surgery?
No.
Like picking up the telephone and then going back to their patient? Is there anything about that?
The assumption is that the circulating nurse is not sterile. She is gloved, but she's not to handle any of the sterile supplies.
Okay.
The scrub tech and the surgeon handle those. So the circulating nurse is responsible for all of the charting on the computer, answering the telephone, and gathering supplies that they need.
Okay.
That's how our circulator works.
And that's pretty standard, having a telephone in the surgical suite. So, yeah,
Right.
that's not unusual. Any other questions?
Okay. Well, thank you guys.
Grab candy.
Sugar in your system.
Candy. From the desk.
Candy. Candy?
Oh, okay.
I gotta go too, so I'm right behind you. I'm just trying not to squish my water too much.
All right, everyone. So I did my project on.
Nobody's in here.
Hold on, Professor Betty
Oh.
left the room.
Okay.
We just want to stare at your face.
I thought the animation was cool.
Thank you. I don't know why there was so much white space.
Oh.
Because when I put it on the TV at home,
It's like,
oh, that could be.
Yeah, so it's my.
That makes sense.
So one thing we learned from Chris,
Yes.
but we've had to learn this too, instructing via IAB when we create PowerPoints and different things, is that you need the font a lot bigger than what you think for it to come across these different sites. So for Sorry Winnemucca, we already
Lesson
But everyone else,
learned.
Just keep that in mind if you have your presentations. Okay. Okay.
But that is a good point. Why is there so much wasted space on the screen?
I think it projects a little bit, it's more full on the screen, I believe, in Elko. I don't know.
Isn't this one
By
called
the time it transfers across the IAD, yeah, the font is smaller than you.
Right? Because I'm like, it looks big enough.
Okay, so we've got Marina, and we'll take a break after Marina. We're moving right along, so.
Good.
Yeah, go ahead.
Okay, everyone. Well, thank you for being here. I did my project on activation of the rapid response team. So in February, I went down to see the ER nurse at the emergency department, and there we discussed some issues going on. One of the issues that we discussed was that the patients were getting confused as to where the ER entrance was. This was confusion because at our hospital, they were remodeling the ER entrance. Therefore, there was a lot of ER entrances. So that was fixed with the help of posters and the use of social media and the radio as well. Another issue that we talked about was increasing education. Better education was given verbally and in written form with easy to read instructions to the patients. The nurse mentioned that increased education helped with decrease the readmissions into the emergency department. Another issue that we talked about was the issue that helped me find my project. She said that there was a lot of code blues being activated at the hospital. In a particular situation, a code blue was activated. The code blue team members responded to the location, but there was no crash cart available. They were waiting for a crash cart from the acute department, which was located downstairs, and they were bringing it with the elevator. At that point, luckily, the patient was not in cardiac arrest. She was just experiencing a syncope episode. But that particular event helped the ER nurse that I interviewed implement rapid response policy. So this is my story. When I apprenticed in the acute department over the summer, I had a patient who was admitted from the emergency department to the floor. I remember his blood pressure being really high. His heart rate was high as well. His O2 saturation was 90% on 5 liters via nasal cannula. He was alert and oriented, and I was able to ask him all my questions. Later on throughout the shift, he started hallucinating. He became verbally and physically aggressive. We had to place him on restraints, and the nurse had to give him Ativan. So, and then after a while, his O2 saturation dropped to 84%, and he was on 15 liters via nasal cannula. Later on, it became chaotic. I was grateful that there was a lot of people there that were willing to help, but everything was disorganized. The patient entered into respiratory distress, and they had to immediately intubate the patient, and then they placed him on a mechanical ventilator and sent him off to Reno with a helicopter. So this particular situation just made me wonder, is there anything I could have done better? Or if the rapid response team would have been available, could they have prevented that event? So what is the rapid response team? It is a team of high-trained providers who are summoned to the bedside to immediately assess and treat the patient with the goal of preventing intensive care unit transfers, cardiac arrest, or death. So in 2004, the Institute of Healthcare Improvement initiated the 100,000 Lives campaign to reduce mortality and morbidity in the American healthcare system. In 2008, the Joint Commission initiated Patient Goals 16 and 16A, and these were initiated to have hospitals have a process to recognize and respond to patients' conditions who are declining. Therefore, hospitals across the United States implemented rapid response team. In one study during a 2-year period, almost 22,000 post-operative Medicare patients died in U.S. hospitals due to the failure to rescue. Failure to rescue is a term described as a failure to identify and intervene in a timely manner on behalf of a patient whose condition is deteriorating physiologically. One of the articles that I read said that the implementation of the rapid response team helped decrease non-ICU cardiac arrest from 83% to 12.7%. So this is my PICO question. How can the rapid response team be activated effectively to decrease code blue activation and increase patient outcomes? So I was doing some research, and Humboldt General Hospital has 2 policies in place. The rapid response team policy is one of them. This policy was initiated in December, and when I talked to the nurse in February, there was no mock simulations in process or education being brought to the staff. This policy has no criteria for calling the rapid response team, only when staff thinks that they need a consultation for the patient. There's also no roles or responsibilities within the policy. There's no calling criteria. And this policy states that the rapid response team members are to respond within 5 minutes. The other policy in place is the Code Blue policy. This one states that all Code Blue team members have to have ACLS training. They have to have, it also describes the location of the crash carts and which crash carts respond to what locations. And with this policy as well, when I worked at Humboldt General Hospital as a CNA, I was also taught, or I was also trained that at least one person from every department is to respond to a code, which is not implemented in the policy. So I did research of successful implementation of the rapid response team. So the first study that I found was nursing surveillance. So a study indicated that when high-level nursing surveillance is performed an average of 12 times or more a day, a significant decrease was found in the odds of experiencing failure to rescue compared to performance of surveillance an average of less than 12 times a day. Evidence-based research shows that certain tools can be used to increase nursing surveillance, such as the Early Modified Scoring Scale. The Institute of Healthcare Improvement indicates that this scoring scale is a guide that determines the degree of declination of a patient by using 6 cardinal vital signs, which are heart rate, blood pressure, temperature, consciousness, respirations, and urinary output. So within the implementation of this scoring score since March 2005, the organization has seen an increase in the number of calls and a decrease in the number of cardiac arrests. This organization has cut its crash call rate in half, going from approximately 8 crash calls per 1,000 discharges to 4. In another study, the use of these warning scales in 2007 were only 361, in which they grew to 1,255 in 2010. Consequently, the percentage of codes occurring outside of the ICU decreased from 51.67% in 2007 to 47.3% in 2010. So another study indicated that communication is very important to the successful implementation of the rapid response team. Communication can have different effects among rapid response team members and hospital staff. Body language, negative remarks can all lead to delay in activation of the rapid response team for fear of criticism of the rapid response team members. Improper delivery of the SBAR report can lead to a delay of care in the patient and can also contribute to medication errors and further deterioration of the patient. Communication amongst rapid response team members has been enhanced due to proper SBAR simulation training and awareness of their own attitudes and how to use therapeutic communication among staff to encourage that a call is better than no call. Other studies show that family-initiated activation of the rapid response team is really important. If anybody knows the patient, it is definitely the family members. Family members can be one of the most beneficial members of the healthcare team. that can notice a differentiation in baseline, therefore activate the rapid response team sooner. Most families also wish to be more involved in the plan of care for their loved ones, so this will help them be involved in the care. So most importantly, education helps with the successful implementation of the rapid response team. In a study, it indicated that nurses who have an associate's degree or less than 3 years of experience were less likely to activate the rapid response team, but would do so at the request of another nurse or a physician. Whereas compared to a nurse who has a bachelor's degree in nursing or 4 years or more of experience, they activate the rapid response team independently. Therefore, education and experience is very important to activate the rapid response. So education could be provided by many different ways. The Institute of Healthcare Involvement indicates that education helps with activation by doing a fast, accurate, critical patient assessment. Education improves communication skills. It links to fewer codes and lower mortality, and it enhances a culture of safety for the patient by improving opportunities, enhanced clinical skills, earlier detection and response to deteriorating patients. So based on the studies, I have come up with my recommendations. So my first recommendation is doing mock simulations. So I would recommend at Humboldt General Hospital to initiate those mock simulations since this policy was initiated in December, and when I interviewed the nurse in February, there has been no training done. So I think it is very important to do that training. And they could do training by using a SINMAN like how we use here, nursing students. A SINMAN provides with the opportunity to apply knowledge, develop clinical judgment, and practice psychomotor skills. These scenarios also provide the healthcare team with an opportunity to maintain a level of competence with uncommon or rare situations in a safe learning environment. It is important to do drills once a month or randomly to help prepare the rapid response team because it could be activated at any time. It is also beneficial to provide training to night shift and day shift to implement the rapid response team. Implementation with night shift and doing night shift training is very beneficial because studies have indicated that the rapid response team is activated more frequently at night because there's a lack of physicians during night shift. It is important to use data collection tools and help the rapid response team conduct SBARs and reason for calling rapid response teams and interventions and help them properly document that information. And most importantly, I think, is conducting a debriefing after simulation. That way they could help improve any weaknesses such as improper following of an algorithm, better interventions, communication, and teamwork. I would also encourage Humboldt General Hospital to clearly establish roles between rapid response team members to decrease errors and improve patient care. The Institute of Healthcare Improvement has a recommended tool. It states that the floor nurse would give a small SBAR report that includes signs and symptoms, allergies, medication, past medical surgical history, last meal, and events precipitating to that occurrence. And the rapid response team registered nurse would conduct her assessment, vital signs, blood glucose, cardiac rhythm, fluid status, etc. And the respiratory therapist would work on breath of sounds, oxygenation, ventilation, and airway clearance. It is also beneficial to help the rapid response team members by doing communication workshops. These communication workshops can help enhance those communication skills so that rapid response team members are aware of their own body language, their tone of voice. That way the staff is less reluctant to call the rapid response team. So I would also recommend that Humboldt General Hospital establish a calling criteria, although I think it is important that the Humboldt General Hospital policy says that the rapid response team can be activated when the staff has a concern for the patient. I also think that there should be like vital signs parameters trigger activation. There's also studies about having an electronic modified early scoring scale, which is already implemented into the EMAR system. So once you input the vital signs, each vital sign is given a score from 0 to 3. If the final score is greater than 4, then it automatically triggers the activation of the rapid response team. So I would also recommend Humboldt General Hospital going about with initiating family-initiated activation. Families are usually the first people to notice a change in the patient. It is very important, though, to teach them and educate them on how to activate the rapid response team. So by providing pamphlets and information with posters in the room, they can know how to activate the rapid response team, and it is important to educate them that it should only be used to if there's a condition of the if the patient's condition is declining, not if they have any questions that could be answered by the primary nurse or if the patient needed something. So in conclusion, I would talk with the creator of the rapid response team policy, which is the nurse I interviewed. I would tell her to establish clear roles and responsibilities within the policy, along with calling criteria. I would tell her to immediately start doing mock simulations and training for the staff. That way, if the rapid response team were to be activated now, everybody would know what to do. And I think it would be also important to, if they decided to do a family-initiated activation, to bring awareness to the patients and the families as well. And that was my presentation. Yay.
Anyone have any questions?
So Marina,
Good job,
I have a question. Yeah, you're not gonna get away that easy. So just to clarify that HGH they have a rapid response team, but
Yes.
but really no, like it's pretty much if a nurse feels like it, they call them. Is that what they have currently?
Yeah. Yeah, that's what it says in the policy. So I think it is important to have like vital signs parameters, and like what I mentioned before. So it has been implemented. Like the doctor has confirmed that the policy is in place, but there has been no training either with the staff or with the rapid response team members, and it's already March, so they haven't done anything like that. So I think it is important for them to get on board and start doing that.
Got you. Yeah, it's kind of like in the last presentation where she was talking about how vague the traffic flow policy was. It's kind of the same type of situation where it's vague and really there's no guidelines for anybody to be compliant.
Yes, definitely.
Great job, great idea.
Know about it? I haven't heard anything since I've just been
Yeah,
there.
no,
Wondering.
I didn't even know about it until like until I interviewed the nurse and she pulled up the policy. But in like, well, because I mostly work in the acute department, so most of them don't know about it, just the manager, and which I think is an issue because everybody needs to be taught how to implement this policy if it were to happen. So.
Yeah, failure to rescue has become a huge thing and a huge problem in all healthcare settings, and as a response, they've developed the rapid response team. So having one but not really knowing you have one is kind of defeating the gist of the idea.
Yeah. It really is scary. It really is scary.
You're going to have to be the catalyst then to get that moving.
Yes, ma'am.
No pressure.
Okay, any other questions for Marina? Okay. Thank you. I don't think we've invited people, I don't think anybody's coming, so why don't we take a break now and we'll just keep moving forward? Does that work?
Sure.
You guys want to take 15 minutes or 10, 15?
Hey, Professor Warner? Yes. I have a meeting with a student at 2:30 and I need to be here for the presentation at 3:10. So,
Okay.
just to let you know or ask you to stay on schedule for that one?
We can switch them if we have to.
Okay, I would suspect my meeting would not last longer than a half hour.
Okay, well, if we have to let Kelsey go before Melissa, then we'll do that.
Okay,
Okay.
thank
So,
you.
2:30, guys. Okay.
I think she must be like
5 months. Hey Cynthia, we're wondering how far along you are.
Sorry.
Super cute.
I am 34 weeks tomorrow.
Congratulations.
Oh, thank you. Thank you. I feel like a guru from like the doctor.
Okay, I think it looks like almost everybody's back. So Jessica's gonna get us started. Okay, so we're going to start. Jessica's gonna talk about the emergency room.
Yes. Okay, so my topic today is decreasing patient violence in the emergency room. This big. Okay, so I chose my area of interest to be the emergency room here at Humboldt General Hospital because right now I am working as a nurse apprentice, and I'm hoping when I graduate that I will continue to be able to work there as a registered nurse. So the nurse that I interviewed is Robin Dunkhorst, who has over 17 years of experience in the emergency room as a staff nurse, and she is currently the emergency room manager. She also went through the Great Basin program, so I think that's pretty cool. So during our interview, we talked about a couple different things, but the biggest concern that she had that she talked about right away is was safety and security within the department. So violence seen from both patients and family members towards staff is an almost daily occurrence within the ER. We also talked briefly about sepsis because we have seen sepsis grow. The diagnosis of sepsis in the emergency room is seen quite often, and it can have such a high risk of death. But ultimately, we decided that violence was the better topic because currently a new sepsis protocol is in the process of being developed here at Humboldt General. So Robin explained how violence in healthcare is causing a growing level of fear and concern related to work attendance. She stated, when the nurses are afraid for their safety, they are unable to provide appropriate care to their patients. Another concern that she had about violence within the department is how often nurses seem to just look the other way when patients are violent or rude with the excuses of, oh, the patient is just sick, they're not feeling well, or they're in pain. So that needs to be addressed. Let's see. So from my research, I actually had a hard time finding studies that have been completed or have been done about ways to decrease violence. But 3 good topics I found was implementing a violence assessment tool, violence warning markers, and then consistent consequences for offenders. Okay, so violence. In the Merriam-Webster dictionary, they define violence as the use of physical force so as to injure, abuse, damage, or destroy. I wanted to know if violence was as big of a topic within the emergency room here at HGH as the rest of the nation. I've been fortunate enough to have not had violence be aimed directly towards me while working in the emergency room. But Robin shared a survey with me that was recently completed involving the 14 full-time staff nurses at Humboldt General, and this survey was in regards to their experience with workplace violence. Okay, so as you can see here, I just took a snippet of one of the questions, and out of the 14 nurses surveyed, 13 of them have ever witnessed or been a victim of threatening behavior, a violent incident, or verbal assault while at work. that is 93% of the employed emergency room nurses having been victims of abuse while working at Humboldt General Hospital. This is a small little clip of the violence problem, but a better view of the problem would be a survey of a larger group, a larger poll of ER nurses, and that has been narrowed down to the last 6 months to a year. This is a huge problem with the majority of this small population having experienced such violence at work here. So current practices, even though obviously this is such a big problem at Humboldt General, we do not have a policy or procedure in place for handling these sorts of violent patients or incidents. So right now the violent incidents are being handled on an incident by incident basis. There is a need for the development of a protocol as violence is becoming more and more prevalent in healthcare today. So the PICO question that I developed for this research topic is, what is the best practice for decreasing patient violence against emergency room nurses? So I have a little video for you that I found. It's a news clipping from, or a news broadcast from out of California.
In tonight's special report, nurses say they won't stay silent any longer about violence from patients.
Healthcare workers are nearly 5 times more likely than other employees to suffer violent acts at work. CBS News' Rachel Kim looks into what's behind this dangerous trend.
It all happened at this hospital behind me.
A firefighter and 2 employees of the hospital were stabbed also.
Stabbing the very people trying to help him.
As an emergency room nurse, I have been slapped, pinched, spat on.
Emergency room nurse Elizabeth Hawkins is talking about the hazards of her job.
I want to make sure that I'm coming home to my family every night, that the other nurses are going home to their family.
In 2013, Hawkins suffered a concussion and severe injuries when she was attacked by a mentally ill patient.
Came over full fist into my head. I was on a rolling stool at the time, so I flew into the wall. It took 4 grown men to hold him down.
Hawkins didn't return to work for 3 months. The patient was never charged. Elizabeth's story sounds horrifying, but it's not unusual. Violent injuries among healthcare workers in California doubled between 2011 and 2012, with rates continuing to go up in 2013. Now, medical personnel, especially in the ER, worry each night that their lives are at risk.
Say 10:30, 11 p.m. I was at the nurse's station.
4 years ago, emergency room nurse Maria Gaitan suffered severe neck injuries when she was attacked by an intoxicated patient who tried to choke her with a stethoscope.
She had the stethoscope with a good pull. I was not trying to pull back because I knew that she could probably choke me if I tried to get out.
Gaitan was out of work for 6 weeks. Today, she chooses not to work weekend nights when substance abuse cases in the ER are at their highest. Both she and Hawkins are now joining other nurses demanding better protection for hospital personnel.
We've had reports of nurses being pummeled to the ground, assaulted in the emergency room, cold-cocked by patients.
Nurses Union Executive Denise Duncan says she's seen the increase in violence and points to one key reason why.
Mental health patients are now being boarded in our healthcare facilities because of lack of mental health beds.
Okay, so I'm just going to leave right here. So that video that we just watched, it really brings to light just how often violence can be experienced while on the job. As I said earlier, there are many excuses said about violence and misbehaving to make it okay. It has even been said that violence is just part of our job, which definitely is not the case. By making these excuses, the problem will never be addressed or fixed. The following recommendations, I believe, will help to provide a safer work environment and hopefully help provide early recognition of a future violent event towards a nurse or other healthcare worker and allow time for the appropriate intervention to be put into place. So these recommendations that I found from research include, again, a violence assessment tool, violence warning markers, and then consistent consequences. So my first recommendation that I believe would be the easiest to implement and would be the most effective is the use of a violence assessment tool. This specific tool that I found was developed in 2010 by a panel of 11 expert nurses from both the academic and clinical nursing field. The end result comprises 17 cues of potential violence that can be easily observed and requires no prior knowledge of the perpetrator's medical history. These cues include threat of harm, aggressive statements or threats, intimidation, clenched fists, resisting healthcare, prolonged or intense glaring, name-calling, yelling, increase in volume of speech, irritability, walking back and forth to the nurse's area, walking around confined spaces such as the waiting room and the patient room, sharp or caustic retorts, demeaning inflection, belligerence, demanding attention, and then humiliating remarks. Excuse me. This assessment can be completed for every patient quickly and without their knowledge. This tool has the ability to prevent further escalation by identifying patients who are at risk for violent acts. Unfortunately, this research did not include a specific number of cues that would be needed to actually list the patient as having a risk for violence. In order to implement this into daily nursing practice here at Humboldt General Hospital, it would be necessary to meet with the ER department manager, get her approval on using this tool for each patient seen, and then deciding on a specific number of the 17 cues to deem that patient as a risk. This tool would be extremely beneficial to a small hospital such as the one here in Winnemucca, as we do not have access to security personnel like most larger facilities do. Early recognition allows time to have the appropriate authorities respond if necessary, which includes law enforcement. Another benefit is that this tool would cost no money to implement into daily practice. Okay, the next recommendation that I have is the use of a violence warning marker. And this would be used on previous and repeat patient charts. So this violent marker will allow for anyone taking care of the patient to know right away that the patient does have violent tendencies or has been verbally or physically abusive in the past. This marker would essentially be an additional icon that would be added on to the charting system that would pop up at the time of admission to alert the nurse or healthcare provider of said patient's past. Again, this early alert for the possibility of violence allows the nurse to be extremely vigilant and attentive to changing behaviors around the patient. So here at the emergency room at Humboldt General, we use a charting system called Emergency Department Information System, or EDIS, which is a program run by MedHost. And in order to be able to implement this recommendation into practice, we need to first of all get the go-ahead from the manager. And then it would be important that we meet with the EDIS coordinator of the hospital. And from there, we need to meet with MedHost themselves to be able to see if they even have the ability to add such a pop-up to the EDIS system. If available, the change would depend on the cost of such an add-on and whether the department and hospital believes this to be a necessary change. In my opinion, the safety of the hospital employee greatly outweighs any cost of the addition of such a change. Okay, so, and then my third and final recommendation is consistent consequences for violence and abuse, regardless of each patient's gender, race, illness, or economic status. To provide a safe environment, Ranker, Scribner, and Huff stated, there needs to be a standard policy and procedure on how violent patients are to be handled. I believe that each patient deserves a verbal warning to violence, depending on the severity, and if after a verbal warning the mistreatment continues, the house supervisor and/or department manager should be notified, and dual nurses should be used to enter that patient's room. If no change in patient demeanor, additional action should be taken, such as notifying of law enforcement. One possibility is adding a posted zero tolerance sign in each patient room, which would outline the consequences of violence or verbal or physical abuse towards healthcare and nursing staff. Excuse me. To ensure compliance with these consistent consequences, it must be supported by all of the department managers, not just the emergency room department manager. And then we would need continual promotion of these procedures with all of the nursing staff. The hope behind consistent consequences is that these patients see that their mistreatment or acting out will no longer be tolerated, and they will either attempt to seek care elsewhere or realize their actions will result in consequences such as arrest. So, by identifying possibly violent patients, family members, or visitors early on during treatment, the likelihood of violent events will be decreased as nursing staff have the ability to intervene before the actual event is able to happen. The violence assessment tool can alert staff to a patient that is at risk for verbal or physical abuse and violence before escalating to that point to allow for the appropriate intervention. The violence warning marker provides an alert that the specific patient has been violent in the past and allows the staff to prepare and be extra vigilant to changing behaviors. And finally, consistent consequences reflect zero tolerance to violence and will result in the specific consequences outlined. The overall care provided within the ER is going to drastically improve, with nurses being able to have their full attention on other critically ill patients without having to worry about their own safety or the safety of the other patients that are being seen. Okay. And then my references. Does anyone have any questions?
So who decides if law enforcement gets involved?
I think it would be up to, no, none of these said it would be up to probably the nurse's discretion, yes.
Okay, I was just curious.
Do you think that maybe nurses or any person in the ER would benefit probably from taking some self-defense classes and learning some techniques to know what to do if someone were to come and charge at them, and what to do in this situation, and should the nurses have a right to defend themselves without having without getting in trouble or anything like that, or laying hands on a patient?
Right, so currently at Humboldt General Hospital, I don't know if they're still doing this, but they were providing CPI. It was called CPI. It was like a self-defense class. I actually never took it. But they were doing that. I haven't heard anything of it recently, but it probably would not be bad to begin them doing it again. But I didn't have any research on that I found.
Good question.
Thank you.
Jessica, this is Cynthia in Prompt. Did any of these research studies consider patients who are altered, or are these just patients coming into the ER for different reasons, like intoxication, or patients that are just being jerks?
So I think a majority of the research that I found was focused just on, it didn't differentiate between whether they were intoxicated or whether they were just, unhappy with the care they've received. I think these altered patients with such as a head injury or something, they need to be taken care of on, I think that's the one I think if someone has such an injury, such as a head injury, or is altered for a reason other than substance abuse, it should be handled on a different level, because oftentimes those patients don't know what they're doing. These intoxicated and just mean patients should essentially know better, but they didn't specify.
Thank you.
Yeah, thank you.
Other questions? Okay. And I don't, did not look. Dr. Meddy, are you there? think you're hiding.
No, she's not here.
Okay, there's like a glare. I'm like, I don't think she's there. Okay, so we're going to like. Do you expect anybody to come? No. Okay. We're gonna let Kelsey go then, and then we'll let Melissa. As long as you didn't like severely enough to get yourself awake for 15 minutes. It's hard to remember.
Like seriously.
What happened?
Okay.
Are we all ready?
Let's let Kelsey get going.
Okay, so I decided to investigate strategies on improving parental engagement for school nurses. I interviewed one school nurse at Mountain View Elementary School in Elko, Nevada. She has been working there for nearly 1 year. At first, she did not have any areas of concern in her field. She even asked if I would like to hear about her experiences as an ER nurse because there are more easily identifiable areas in need of improvement. But she was more than happy to discuss her position as a school nurse instead after I explained that I'm much more interested in pediatric nursing. As the interview progressed, I could see why she suspected that I might have difficulty identifying an issue to address for my project. Evidence-based research is the standard in the school setting, and practice is kept very up to date. Throughout the school year, there is a meeting, evidence-based research is being reviewed by her and her coworkers regularly. Multiple members of the team attend seminars on the most recent practice guidelines for different areas of care. For example, one person may attend a seminar on how to best promote healthy eating. And then before the school year begins, there is a meeting held to educate one another on what was learned at the seminars that each one of them attended. Throughout the school year, there is a meeting every week, which is really frequent, to discuss any concerns or share any articles that they have found. There's also conferences on health promotion that are held that include other school staff, such as the teachers. Though the standards are kept high, there is always room for improvement. The nurse collaborates with many people and has a population of 80 children assigned to her, so it's quite a few. For each child, there's a teacher, caretakers, and sometimes other medical professionals, such as a primary physician. To provide optimal care for each child, collaboration between those responsible for his or her care is going to be essential. As me and the school nurse discussed common patient diagnoses that she sees throughout her days, there was an area of concern that kept popping up, which whether we were discussing lice, allergies, or vaccinations, there was always a mention of parents lacking understanding or believing myths. For example, some believe that vaccines cause autism. Most parents truly want what is best for their children, and it is in their best interest to be aware of best evidence practice guidelines so that their child can receive the best care possible. Educating parents is an important role of the school nurse, and the best known educational methods should be used to optimize parental engagement. Parental engagement is necessary to raise awareness about how to best care for their children. And parental engagement is not something that the school nurse can entirely control, but she can apply the evidence to promote it the best way that she can. So, what is parental engagement? According to the CDC, parental engagement is defined as parents and school staff working together to support and improve the learning, development, and health of children and adolescents. And it's really important. Parental engagement strongly correlates with children that get better grades, have a higher intake of fruits and vegetables, have a higher activity level, so then they have a higher have higher rates of a healthy BMI. They also tend to have better social skills. They are less likely to smoke tobacco, drink alcohol, or use illicit drugs. They're also less likely to engage in risky sexual behavior. And also, school health activities tend to be more successful. So currently, parental engagement is something that is promoted in this nurse's clinical area. All parents are provided with her contact information and encouraged to come with her for any concerns. There is also a monthly newsletter on various health topics that are sent with the children home for their parents to read. There is also health assemblies that have been held at the school for parents. And these are all great methods because they provide educational tools, opportunities for parents to get involved, and opportunities for the nurse to provide education and develop closer relationships with these parents. So, what I wanted to know is if school nurses use the proposed recommendations that I'm about to discuss with you to increase parental engagement in addition to the current methods that they use, will parental engagement improve? So there are a lot of recommendations. I mainly looked at what the CDC had to say, and another little branch of the CDC is called Parents for Healthy Schools. They also had lots of recommendations, and also the National Association for School Nurses. So since there were so many, I decided to stick to a few main ones that I thought would enhance the things that they're already doing to promote parental engagement. So the first recommendations I wanted to discuss are aimed at improving convenience for parents, because schedule conflicts often interfere with parents' ability to get involved, even if they are interested. Ways to accommodate diverse schedules include surveying parents to see which times and days are best for them, and scheduling more than one meeting and activity opportunity. Hosting school meetings off school campus can also help make it more convenient. Good choices for alternative meeting locations include community centers and places of worship. The other recommendations I thought would be good are the recommendations that are aimed at providing incentives for parents to be engaged and to attend health activities. Sometimes they just lack interest. It probably doesn't sound fun. But providing incentives at these activities might improve attendance. Good incentives include food and beverages. Providing childcare is also a way to get a parent's interest. Bringing young children to activities can be a bit of a hassle, and instead parents can get a break. Making activities that actively engage the parents can make them more enjoyable. It's even better if it's possible to offer prizes for winning games or perhaps a raffle. Oftentimes, businesses will gladly support local schools by donating gift cards and other items that can be used. Some other recommendations that I found are ways to use the internet. The internet is a great means to make it convenient for parents to stay current on school health events, and it's also convenient for the school nurse to share information this way. A great way to do it is to create a tips for parents YouTube channel. I was actually able to find a couple on YouTube that school nurses have done in the United States that I thought were pretty cool. In addition, meetings can be streamed live online so that parents can be involved from wherever they are. These meetings can be recorded and made available to be watched anytime as well. Many online applications used for streaming are designed so that parents can ask questions through written comments that can be posted live or later. Comments that are made later can be answered in comment form by the school nurse. So there's lots of applications, I'm sure most of us are probably familiar with, Facebook Live is basically what I'm talking about. In addition, if the school has a parent newsletter, website, or blog, the school nurse should consider posting relevant health information and resources at least monthly, and the nurse's contact information should be included. And here I just have a little example of how the internet can be used. This was a video that I pulled from one nurse's YouTube channel that she has set up for parents to provide them tips. And normally I just have to double click and it plays it for me. Can I not? Sorry guys, hold on. This worked earlier. I don't know what's going on.
Can you find it really quick on YouTube, maybe?
I think so. I don't even know how to exit full screen.
On the keyboard?
I don't have a keyboard. Would it make a difference if I started here and clicked through?
Or if you hit enable editing in that yellow box.
Oh.
That might help. I don't know.
Enable content. There we go. Thank you. Thank you very much.
Possibly.
Well, let's start over. Yeah. Sorry about that, you guys. Can you guys hear that?
No.
Can you turn it in? I have my volume up all the way. I don't know how to. Okay. Is this how you do that right here? I apologize.
You can turn the volume down for Ivy.
Yeah.
Okay.
Because that's gonna
Yeah,
that's gonna be a little loud.
Okay.
Brr, it's cold out there. Hi.
We turn it all the way up. I always hesitate to do that though, because really.
Yeah, it gets so loud sometimes.
Brr, it's cold out there. Hi, my name is Lois, and I am the school nurse manager for the school district in the city of Waterbury. I'd just like to talk to you today and give you a few tips about how to prepare your children for this cold weather when they're going out to get the school bus in the morning. There are certain tips that I think will help you make sure they stay warm. Head, face, ears, fingers, and toes. Children lose 80% of their body heat off the top of their head, and if that happens, they can become chilled very easily. So it is absolutely imperative that your children wear hats on these very cold mornings. A hat like this that covers the ears and the whole top of the head would be a great option. For the face, they can either wear a turtleneck, pull up a neck warmer, or you can simply take a scarf and wrap it around their face until they get to school. Fingers and toes. Little fingers and toes get frostbitten very easily, very quickly. I recommend that for school children, they wear mittens, which can be tucked into their jackets if possible. That will keep those little fingers very warm. For the toes, they need to wear warm woolen socks and boots that are lined. Now what about the rest of the body? Well, layers are a must. First layer, which should be nearest the body, should be a well-fitted t-shirt type of thing. Even under their slacks, they should wear well-fitting long underwear. Then they could have a turtleneck or a fleece. And lastly, they should wear a warm coat that is zipped up and preferably has a hood. And you know what? There's nothing better than a cup of hot chocolate when they come home from school on a cold day. Don't forget the marshmallows.
Yeah, so she has like a whole entire YouTube channel. She tries to have fun with it, and I think it's a little bit like more personable. Like she introduces who she is and actually demonstrates what she's trying to get across to you, and I just thought that was a really good way to go about it. So, to implement what I would like to do, I would want to create a presentation to share these recommendations with school nurses at the Mountain View Elementary School. There's only 2, but and I would need to propose my idea to share this presentation to the director of the school nurses for approval. After my presentation, I can hand out surveys to the school nurses that evaluate how they feel about the current level of parental engagement, how knowledgeable they are of my recommendations, and if they plan on including any of them into their practice. I would want to do a follow-up survey to see if they actually implemented any of my recommendations and to reevaluate how the nurses perceive the level of parental engagement. And at the end of the school year, I think would be an ideal time to do that. And that's everything. Those are my resources. Do you guys have any questions?
I have a question. Well, it's not really a question.
Okay.
So would you want to implement it to other schools or just the one that you...
I was focusing on the Mountain View school in particular, but I think that these recommendations could be useful for any school setting, really.
Okay.
I have a statement.
Okay.
I think you look super cool. I don't know why.
Thank you, Sing Sing.
It's her newer haircut.
Anybody else? Okay, thank you.
All right, are we ready in Elko and Pahrump?
Yes, ma'am.
Ready and Pahrump. All right. So today I will be talking about delayed bathing. Specifically, I will be talking about delaying the initial newborn bath for at least 12 hours. So I chose the OB unit at Humboldt General Hospital to do this project on. I chose OB because I had 2 really great clinicals last semester, and then I also apprenticed over winter break, and I really enjoyed it there, and I'm planning or hoping to get a job there after graduation. So let's start with my interview. So I interviewed Catherine Norada, who is a registered nurse with more than 20 years of experience at HGH. During our interview, she discussed several concerns that she has on the unit. So the first one she discussed was that currently there is a delay in obtaining IV access in someone who presents with spontaneous rupture of membranes. She said that this concerns her because of the safety issues that can be associated, like cord prolapse. The second concern she had was that sometimes patients who are group B streptococcus positive aren't being treated. Specifically, she said that there's a doctor who won't treat GPS positive patients, so this is where her concerns stem from. And then the last thing she talked about was the current inconsistencies in bathing newborns at the hospital. So she said that the policy isn't specific regarding the time frame that they should be aiming for, which is what is causing the inconsistencies. So we also discussed current current quality improvement initiatives that they have implemented within the last year. So she stated that currently they started skin-to-skin contact between the mom and the infant for the first hour after birth. She said that they did this because it is evidence to stabilize the baby's body temperature, breathing, and heart rate. They have also implemented putting babies on their backs to sleep, whereas previously they were putting them on the side and rolling up a blanket. But now they put them on their backs to sleep, and that's part of the back to sleep campaign. They also now use sleep sacks, so instead of putting the baby in the blanket, now they have a sleep sack and it just clips on each side. And they also now make sure that there's no blankets in the crib or anything else in the crib, and that also decreases the risk of sudden infant death syndrome. In October, they implemented, so they previously did shift report at the nurses station, and in October they switched over to bedside shift report. The nurse said that doing bedside shift report gets patients involved, increases awareness regarding the nurse and the role, and decreases patient anxiety. She also stated that bedside shift report benefits nurses by increasing accountability, assessing the patient early, and improving prioritization of care. So based on my interview, I decided to do my evidence-based practice project on delayed bathing because that was a concern that stood out to both the nurse and me. So at HGH, the current policy states when infant is thermodynamically stable, bathe infant with infant soap and water. So as you can see, the policy is pretty vague. It doesn't specify that the actual bathing times for the newborns or the time frames that the nurses should be aiming for as to when they do the initial bath. So the current practice is that, so they're currently bathing newborns at various hours after birth. Nurses are bathing at their choice of time, which is impacted by unit status and other responsibilities they may have. So if a newborn's temperature is stable, so between 97.7 and 99 degrees Fahrenheit, a nurse can bathe an infant even if it's only been 2 to 3 hours after birth, whereas a nurse who has many responsibilities, she might have other patients or a patient in labor or has to catch up on charting, might not bathe a newborn for like 6 to 8 hours. So as you can see, that's inconsistent, and it varies as to when the bath is performed. So currently newborns are being bathed from 2 to 8 hours after birth. So after doing my research, I started seeing that delayed bathing was something that was coming up over and over again. So my PICO question became, what is the effect of delaying the initial newborn bath for at least 12 hours on transition to extrauterine life, breastfeeding success, and infection compared to performing a bath within 8 hours of birth? So research suggests that there are benefits of leaving the vernix on the newborn skin. So vernix is a thick, white protective fetal film which acts as a chemical and mechanical barrier in utero. Leaving the vernix on the patient's skin allows it to be absorbed, and it has several benefits in the postpartum period. So benefits of leaving the vernix on the skin include protection from infection, it improves skin barrier function, it provides skin cleansing and moisturizing, and it helps with development of acid mantle. An acid mantle is a protective film on the surface of human skin which acts as a barrier to bacteria, viruses, and other potential contaminants that might penetrate the skin. And it also assists with temperature regulation. So the benefits of leaving the vernix in place on the skin increase newborn safety by decreasing the risk of infection. It also helps with regulating the temperature. Evidence has also suggested that there's a potential to increase breastfeeding rates by delaying the initial bath. In a study which was published in 2013 and it was performed on 702 infants, the result indicated that exclusive breastfeeding rates in the hospital were 39% greater after a new policy was implemented to delay the initial bath for at least 12 hours. The new change also determined that infants were 166% more likely to initiate breastfeeding in the hospital. Delaying the first bath also decreases mother and baby separation, which allows infants to spend more time skin to skin with their moms, thus initiating breastfeeding sooner and for longer periods of time. So evidence also suggests that it decreases the risk of hypothermia. So newborns have reduced thermoregulatory capacity and lose heat via convection, conduction, evaporation, and radiation. Early bathing is a stressful event which can lead to hypothermia. Delaying the bath for 12 hours allows the body to adjust and has shown to increase newborn safety by decreasing the rates of hypothermia. So normal auxiliary temperature for newborns ranges between 97.2 and 99.9 degrees Fahrenheit, and lowering the body temperature even by 1 degree Celsius or 1.8 degrees Fahrenheit can be clinically significant with notable behavioral changes. These changes can contribute to impaired breastfeeding behavior as hypothermic newborns mobilize metabolic resources to reestablish temperature homeostasis. So although it has been shown that delaying the bath decreases the risk of hypothermia, there have been several studies that have been published that state a healthy newborn can be bathed as early as 1 hour as long as their body temperature is 98.0 degrees Fahrenheit or higher prior to the bath. And it is also important that appropriate care is taken to support thermal stability, such as maintaining higher ambient room temperature, using radiant warmers, and making sure the baby is wrapped in a warm blanket after the bath. Although the healthy newborn can be bathed as soon as 1 hour, it is important to consider the potential benefits to delaying the bath like I have discussed. So evidence also suggests that by delaying the bath, the risk of hypoglycemia is also decreased. Early bathing is stressful, so it can lead to hypoglycemia because the baby's body is working hard to respond to the stressful situation. Newborns who are cold stressed have an increased metabolic rate, demanding increased use of glucose and oxygen, which can then lead to hypoglycemia and hypoxemia. Additionally, a hypoglycemic newborn can quickly become Additionally, a hypothermic newborn can quickly become hypoglycemic as the physiologic response to try to increase body temperature uses up the infant's glycogen reserves. A study which was published in 2015 and was performed on 1,135 newborns demonstrated that newborns who were bathed within a few hours had an 8.5 occurrence of hypoglycemia on the initial blood glucose measurement. Hypoglycemia was indicated as a glucose level of 49 or less, compared to the 3.5% of occurrence of hypoglycemia in newborns who were bathed after at least 12 hours. So as you can see, that's a 5% decrease in hypoglycemia, and that was in a 6-month interval. So based on the evidence-based practice research I gathered and synthesized, I created 4 recommendations with the help of the articles I was looking at, which could be used in the OB unit at Humboldt General Hospital. So my first recommendation is that a newborn's initial bath should be delayed for at least 12 hours after birth. I'm making this recommendation because several articles that I found all evidence that waiting to bathe the infant for 12 hours has benefits. Like I previously mentioned, these benefits include allowing the vernix to provide antimicrobial, moisturizing, and temperature stabilizing effects, possibly increase breastfeeding rates, and it has the potential to decrease the risk of hypoglycemia and hypothermia. And it also decreases mother-infant separation, which will decrease the newborn stress and allow for breastfeeding to occur sooner. My second recommendation is that newborns should be bathed in private hospital rooms with parent participation. An article that was published in January of this year evidences that by implementing delayed bathing, it allows time to facilitate family education and increases parental involvement with bathing. The article suggests that after at least 12 hours following delivery, the newborn should be bathed in the postpartum hospital room. Waiting at least 12 hours to bathe the newborn also gives the mom plenty of time to rest and be prepared to participate in bathing. Demonstrating how to bathe the infant allows for enhanced education about safe infant bathing, which is a benefit since it's an activity that can be intimidating for parents, especially for first-time parents. Allowing parent participation will help parents be more ready to bathe their baby at home, and it will also help establish that safe bathing procedure to be followed upon discharge. My third recommendation is that a whiteboard checklist should be placed in the patient's room. Next to the section in the whiteboard for newborn bath, a sticker saying greater than 12 hours can be added, and the sticker will indicate that the newborn will be part of the delayed bathing protocol, and it will also remind parents that bathing will not occur until this time frame has been met. My fourth recommendation is that after providing parental education, the parents should be allowed to make the decision as if they want their newborn to be part of the delayed bathing protocol or not. If parents do not decide to participate in delayed bathing, newborns should be bathed after being thermodynamically stable. So this means that an infant needs to be able to retain a temperature of 97.7 degrees Fahrenheit to 99 degrees Fahrenheit for at least 1 to 2 hours after delivery. In addition to this, newborns with critical conditions like respiratory distress, who are unstable, have like cardiac issues, or are preterm should not be delayed until their condition is stable. And also infants who need to be shipped out will be shipped they will be shipped unbathed because we won't do that at the hospital. So in addition to this, there are certain conditions that exclude newborns from the recommendations that I talked about. So newborns born to mothers with hepatitis B, hepatitis C, MRSA, and HIV will not be part of this protocol or the recommendation that I talked about. The reasoning is that we want to decrease their possible contamination to infection, and evidence suggests that newborns born to mothers who are HIV positive should be bathed as soon as possible after they are stable, and they should be bathed before skin-to-skin contact is initiated to decrease the possibility of infection. In addition to this, infants born to mothers who are hepatitis B or hepatitis C positive should be bathed after the first hour of skin-to-skin contact with the mother, and this is what I found in my research articles. So the first step in implementing the recommendations that I talked about would be to talk to the OB manager. So I talked to her and let her know of what evidence-based practice has to say and about the research that I found and the benefits that delaying the bath has. It would also be important to talk to the OB doctors to ensure that they are on the same page as us and they're willing to implement this on the unit. The next step would be to talk to staff members and hold a presentation. It would be important to educate them about why it is recommended to delay the bath for at least 12 hours. I would provide staff members with this information to get them involved in implementing these recommendations. It is also very important that they are involved and ready to cooperate to increase adherence to this new protocol. It is also important to explain to them what newborns are excluded from the policy, and also what conditions that a newborn presents with would cause the delayed bathing protocol to not be followed, like I previously mentioned. So it is to ensure staff safety, it is important to educate staff to wear gloves until a newborn has been bathed to decrease possible contamination to blood infections. The next step would be to prepare the information that needs to be presented to patients upon admission. So handouts or flyers can be made to give to patients upon admission to present why we are implementing delayed bathing for at least 12 hours. The handout needs to cover bath timing, the health benefits of leaving the vernix intact for at least 12 hours, and also the other benefits that delaying the bath has showed. So parents should be asked if they would like to participate after education has been provided. So if parents decide to participate, the sticker on the whiteboard, like I previously talked about, will be placed, and that will indicate that that the newborn will be part of the delayed bathing protocol. And if parents decide not to participate, it is important to explain to them that the newborn will not be bathed until they are thermodynamically stable. So like I mentioned, being able to retain that temperature of 97.7 degrees to 99 degrees Fahrenheit for 1 to 2 hours following delivery. And it's important for them to be aware of this so that they're not concerned as to when their newborn will be bathed. So evidence has shown that there are potential benefits to both parents and nurses. A similar policy was implemented in St. Joseph Hospital in Orange, California, and the results indicate that after being reminded of the possible impact that vernix has on newborn skin and other benefits that delayed bathing has, some nurses reported more satisfaction in knowing that they were postponing the bath to provide benefits to the newborns. Waiting 12 hours postpartum to bathe newborns allows staff to gain more rapport with parents, which causes parents to be more at ease with their babies being bathed since they have built that trust with the nurse. It has also been shown that parents are more receptive to education and eager to participate in bathing. Demonstrating how to bathe newborns allows for enhanced education and safe infant bathing. Increased parent awareness and participation in the bathing procedure will make parents more comfortable at home and also help establish that safe bathing procedure to be followed upon discharge, like I previously mentioned. So, of course, with new policies or new procedures that you are trying to implement, there will be challenges. So nursing staff may be resistant to implementing delayed bathing because of what they consider a yuck factor. So the newborn still has residual blood on the skin, still has that vernix and other possible secretions. So nurses have to continue to wear gloves anytime they handle the baby or anytime they're doing an assessment on the infant, which can be a hassle. So that's why they could be resistant. They also need to institute universal precautions until the baby is bathed. So this includes wearing a gown every time, or when, I guess, they're gonna, if they're gonna carry the baby, they need to wear a gown so that they're not putting any of the blood or vernix or any secretions on their scrubs. And they also need to wear masks whenever necessary. So the last reason for possible nurse resistance is that by delaying the bath, it is another task that needs to be incorporated into postpartum care. So along with all the other tasks that they have, like doing vaccinations, drawing blood, maybe they have to check for glucose, or do hearing screenings, they now also have to bathe the infant. So that's why they could be resistant. So education is very important so they are aware of the benefits and are resistant to these recommendations. So by increasing education, it would also increase adherence to this new policy. In conclusion, delaying the initial bath for at least 12 hours has been shown to have several benefits, like I have discussed. These recommendations I outlined can be implemented in the OB unit at HGH to provide safer and more evidence-based care. So the next slide just has the references for my articles, and then I have my references for my images. Does anyone have any questions?
I have a quick question.
Mm-hmm.
So when you're saying, so are we not supposed to, are they not wanting to wipe the baby off at all?
No.
After birth?
No, so you do the same, what you would do, you would wipe the baby off, get rid of that, like the blood they have and some of the secretions, but you don't like scrub to rub off the vernix.
Okay.
Yeah. So you leave the vernix intact.
So they
Does
wipe
anyone
to dry
have-
but not clean off the vernix, pretty much.
Yeah.
I have a question.
Yes.
They have it, so I know that you're kind of summarizing a lot of the articles for the recommendation for 12 hours. Did anybody talk about an ideal time or?
So 3 of them that I found just said delaying the bath for at least 12 hours, but A1 recommends for at least 24, unless there's, I didn't mention that, but unless there's any cultural reasons, they say at least 6. But the ideal time is at least 12 hours. Does anyone have any other questions? Cool, thank you. You all logged off?
Share the content.
Yeah, we are.
Okay. Yay. So can I go ahead and shut this down, or do we need it?
No, you can shut it down.
Okay.
Thanks.
I don't know. Oh, right here.
Okay, great job. Thank you, Wanamaka, for going first. Actually, I signed you, so you had to. But so Tuesday we have all day presentations, which will be a long day, but we have more interesting topics. And classrooms, I will look at those right now and post a new announcement, making sure everybody's clear. You will not be in these rooms because first years have class. I can tell you that right now. So I obviously on the flyer that I created, I messed the rooms up. Sorry about that. But I think in the module it's correct, but I'll make an announcement just so everybody knows where they're going on Tuesday. Okay. And then if you haven't looked at Module 8 yet, that assignment has a small question about your peers' presentations. I should have told you that ahead of time, but you probably want to look at that. It's very short, so, but before Tuesday, today or before Tuesday, make sure you look at that, so, and when you're listening, you can answer that. Like I said, it's very brief, but you probably want to look at that. And I think that's it for now. Any questions that I can answer for the course, or? Nope. Okay. Discussion this week. You have a small assignment next week, and we're listening to each other's presentations, and then we're wrapping this up. So. Yeah. But then you start 273, so you don't get like a complete break on that.
And don't boo-boo yet.
Yeah, I was gonna say, then you start that. It's not spring break quite yet after that. So, okay, thank you.
Thank you.